My name is Daniel, and today we're going to be talking about the arterial blood gas. So what is an arterial blood gas? It's simply a measurement to see how well the lungs are doing. So we're going to be looking at the oxygenation, the ventilation, and the acid-base balance for all those factors. There are other ways to obtain partial assessments of those, and those can include the regular pulse oximeter. You have the capnography, which is the capnometer, and you have the transcutaneous monitoring. But the reason we're using an invasive procedure is because it's going to give us a whole overview, very accurate, and it's going to give us stuff that others can't. So the next step is to look over the patient's chart. We're going to see why the patient, we're going to see the history of the patient, if they have any anticoagulant therapy going on, if they have a negative response to modified Orton-Allen's test, if they have an allergic reaction to anesthesia, as well as if there is the presence of vascular grafts or shunts. So the next step after that is to grab the ABG kit, and that's going to contain the heparinized needle, 20 to 22 gauge. It's syringe. It's also going to contain 1 cc of anesthesia if applicable. It'll have gauze, the betadine, an antiseptic, alcoholic swab. You will also want to bring gloves, a towel, which I'll get into later, but it's for the Allen's test. Sorry, not the Allen's test, but for the puncturing. You're also going to want a bag, ice bag, just in case you anticipate being more than 15 minutes with transporting and analyzing your sample. And further on with the ABG kit, we'll also have a protection cap along with it, and your bandage, so on and so forth. After that, you would go ahead and apply 3 milliliters of hand sanitizer or wash your hands if they're visibly soiled. Knock on the patient's door, introduce yourself to your department, get the 2 patient identifiers, and explain your procedure. So for myself, I'll knock on the patient's door. I would say, "Hi, my name is Daniel. I'm with the respiratory department, and I'm here to collect an arterial blood gas. Can I get your name and date of birth?" The patient will go ahead and give me that. I'll go ahead and check with their wristband just to make sure everything correlates. And then I would go ahead and explain the procedure like I was saying. I would tell the patient that in layman's terms, we're just going to take this blood gas to get a better idea of how the lungs are functioning and see if there's any underlying disease process there that we could go ahead and tackle. If there's a family in the room, we'll go ahead and explain the procedure to them, make sure everyone's on the same page. There are some risks with any medical procedure, especially the more invasive it gets. So with the arterial blood gas, we can potentially scissor the artery, so that's if we kept going in at that same artery, we could end up severing it. But thankfully, there's safeguards in place, so as a respiratory therapist, you get 2 punctures and you get 1 repositioning. So that's a safeguard. If the RT isn't able to do that, they can just go ahead and grab a fellow RT who will be able to complete the task. Other hazards that can happen with it is the patient, there could be excess bleeding, there could be trauma caused to bruising. You could hit a vein, hit a tendon, you could hit bone. Those are all of the possibilities, but it's good to have a competent RT who is competent in his skills. So the next step after that is you're going to want to make sure that the patient has been stabilized on room air for about 30 minutes. So if they're on supplemental oxygen or a vent, you want to make sure that they're on room air for 30 minutes just to make sure that doesn't affect with the ABG results. So you're going to go ahead and determine what site you're going to use for puncturing. So you have the radial artery, you have the brachial, and you have the femoral. Radial is the quickest, it's the easiest to palpate, known to be a little less painful than the others. So over here you go to 35 to 45 degree angle for the radial artery. For the brachial, it's going to be at a 60-degree angle, and for the femoral, a 90-degree angle is where you would go ahead and puncture. So the next step is to go ahead and begin. We're going to go ahead and palpate, and we'll palpate both arteries because we're going to perform the Allen's test. So what that is basically you have the radial artery on this side, the ulnar on this side. Since we're sampling at the radial, as I was saying before, there's that potential for scissoring. So if you were to do that, we would rely on the ulnar artery to get that perfusion into the hand. So what the test is going to test is to see how well this is if this is functioning well enough. So we could sample from here. Otherwise, we'd have to go to a different site. So as far as this one, just with a conscious patient, we would go ahead and we'd place our index and middle finger on both sides, so we have the radial and the ulnar, and we go ahead and have the patient pump their hands several times until you see it become pale. And what we're going to do is, after the patient goes ahead and pumps, we're going to have the patient let go of their hands so we have a better visualization, and we're also going to at the same time release from the ulnar artery so we can see the blood come back in, and within 10 seconds is what we're supposed to see, and that'll indicate a positive response. And so like I was saying, this is just to see the blood come back in the perfusion. If the patient was unconscious or sedated, we would go ahead and do the same thing, but they're not going to be able to have that motion, so we're going to go ahead and their hand would be open and we'd just be massaging the palm upwards. And yeah, that's that way, if we were to go downwards, we'd go ahead and it'd keep the hand still pink, and that's just going to defeat the purpose. So after we go ahead and we find that the patient has a positive response, we can actually go ahead and palpate and begin our procedure. So, like I said, the gloves would have been on with the patient as you're doing the Allen's test, but since this is a mannequin, it was more of a lecture and theory. Alright. So you're going to go ahead and grab your ABG kit from earlier. You're going to have your needle. This would have been for the anesthetic. You have your bag where you can put the ice in if you anticipated anything past 15 minutes. Gauze, bandage, requisition slip, and the prep pad and the bed done. Okay. So before you begin your procedure, you're going to want to make sure you have your requisition slip filled out. So what this is going to have is the patient's name, the room number, the amount of respirations, the temperature, as well as the time when you actually begin your procedure. So you want to have that at the ready. Everything will be filled out except for the time in which you start. And it's also going to contain, the patient's oxygen, what they're on, if they are on anything, or room air. The next step is to have your gauze and your bandage ready. You can ask the patient if you could go ahead and place it on their arm so it can make it easier. If they don't want it, you can go ahead and place it to the side. It's not a big deal. You go ahead and do the same thing with the bandage. Just go ahead and place it. And then so with the betadine, we'll go ahead and start off with that. We palpate, find the area on which we're going to puncture. So with the betadine, we'd go ahead and start off in the center and move in a clockwise rotation to cover about 2 inches of surface area on the arm. We would then move on to the alcoholic prep pad. Do the same thing, and you want to let it dry because if you go ahead and puncture right after doing it, it's going to sting the patient, cause more pain than necessary. And you do not want to fan it dry because that's going to add more contaminants or potential contaminants to the open area. So after you go ahead and do that, the final part is to actually get the needle out and ready. Okay, so with the needle, you have a little needle stopper over here. We have the syringe and the protection cap. Okay, so we'll go ahead and dispose of that. So what's important to remember about the syringe is although you only need 0.5, so a half a milliliter to collect the sample, you want to ideally draw more to about 1 milliliter or more depending on what's asked, because you might have to share a sample with the nurse. You might have to anticipate that the analyzer might not be working, so you might need to recalibrate, and therefore you'd have that extra sample. If the patient's on anticoagulants, you would want to obtain more of a sample. And Yeah, those are some of the reasons. Okay. So now that we're ready to begin, we're just going to go ahead, have the bevel facing up, and then just go ahead and pop this off. Be careful when working with needles. Okay. Okay, and just make sure 1 milliliter. Okay, bevel up. So if you're thinking of a shovel, you know, the shovel facing, you know, the right position where it scoops. So when it comes to obtaining a sample, just be comfortable, you know, visualize the artery. I like to say become the artery, you know, just because it's going to help you, it's going to help your patient. So go ahead and palpate, take your time. You're going to want to extract from the point in which you feel the maximum impulse. That's going to be, you know, where you feel the strongest beat. Okay. So like I said, bevel up, and you're just going to go ahead and insert. And then you want to just put the bevel in, because the arteries sometimes can move, the patient can move. So just put the bevel in, reevaluate, and then just go ahead and stick. And it's important to tell the patient ahead of time that you're going to go ahead and poke, so they're not too frightened or shocked. So I'm just going to go ahead and tell the patient that, okay, you're going to go ahead and feel a poke now. And then, so you're going to want to lift up the index finger, and then just go ahead and place in there. You're going to want to go until you see a flash, which is indicated right over here. Okay, and let's pull out a little bit. There we go. And so what's important is, just like when you're getting from veins, I mean, with veins you're going to want to draw out. With this, you already have the plunger at a certain amount because the arterial, it comes in pulses. So just go ahead and fill up. It's filling up. It's a little slow, but it is filling up. So as it's filling up, I'll just go ahead and talk about some more after procedures. So when you're going to apply the gauze and hold down pressure, it's going to take about 5 minutes for just a normal healthy person, and about, well, 5 minutes for, you know, regularly, and 10 minutes for somebody who's on anticoagulants. Okay, and now that it's filled up, I'm just going to go ahead and grab the gauze, place it like so, and then remove slowly. Place the needle in the protection cap, not too far deep. Okay. And then you go ahead and twist off. Place the protection cap on, twist, and you're going to want to evaluate for air bubbles. So you're going to go ahead and tap. Make sure there's no air bubbles. You're going to go ahead and plunge just slightly to make sure any air bubbles that were there are pushed out. And you're going to go ahead and do a figure 8 motion, and what that's going to do is that's going to mix with the heparin. And that way we can avoid the coagulation. So after you go ahead and do that, you place it over here near your bag. You would place the requisition slip on it, as well as in the bag. If you anticipate anything past 15 minutes, you would go ahead and have ice in there. Even with ice, you want to make sure that you get your sample done within 1 hour, because if you do anything past an hour, the sample's not going to be valid anymore. You'd have to go back, draw from the patient, take up more of their time, your time. So it's good just to get it done once, right, the first time. So after you go, you want to make sure that the patient stops bleeding before you leave the room. So, and that normally can just be done by just applying pressure. You do not need the bandage, but you could use it as a just extra measure for comfort. Usually it helps the patients out. And so once you're done with all that, you would go ahead and put your sharps in the dispose everything, the needle in the sharps container, trash in the trash. Remove your gloves and go ahead and wash up, leave the room. Go ahead, sample your gas, interpret the results, let the physicians know, let nurses know what you've done, just in case they need anything. And then that way you can go ahead and modify the treatment if need be. So a few other things just to go over. You could get, you can get monitors, non-invasive monitoring through pulse ox, transcutaneous monitoring, or capnography, capnometry. But like I said, the invasive is going to give you a full scope of things: your pH, oxygenation, ventilation. When it comes to sample sizes, they vary depending on the type of analyzer used. Like if you have to recalibrate, like I was saying, the anticoagulants, if, like I said, if nurses need anything. Excess heparin can be a potential problem. It can cause false results and make the patient seem like they have a metabolic acidosis with respiratory compensation. So it could give a total false result, so you got to be on the lookout for that. And then, just the hazards, as I mentioned before. You could scissor the artery, cause excessive bleeding, hit a vein, tendon. There's a lot of these complications that could arise, but it's just important to just to be confident, take the time to do the procedure. It's not a rush. And yeah, that's what I believe encompasses the arterial blood gas. So just covering up, you just go ahead and exit the room and then interpret the results and modify the plan if need be. Thank you.